Morning, all. It's a pleasure to have you here for the Health and the Public Interest weekly seminar. And before we start today, I'd like to turn it over to Adrian Fu-Berman for a brief announcement.
Yes, hi everybody. We just wanted to tell you, and you should have received a written notice as well if you've come to seminar before, but the Health in the Public Interest graduate program will be ending at the end of this year. And so with the grad program ending, we'll be ending the seminar series, but we really appreciate your attendance in it. And we will be reviving a version of the seminar series in September, hosted by Dr. Myers. And it will be under farmed out and will be approximately monthly. So we will be launching a monthly seminar series in the fall. This seminar series, the weekly seminar series, will end on April 15th. But we'll be doing every week until then. And then start up another version in the fall. So thank you for being a great audience.
Yeah, thank you, Adrian. And the seminars will cover basically the same broad range of topics as we've been doing here, and I think which is something that everyone appreciated about the seminar series. So the Health and the Public Interest Program is a program that looks at the social determinants of health, the economic, political, cultural, et cetera, determinants of health. And we'll have the URL in the chat. And I'll also mention that along with the website, we'll maintain the YouTube channel that hosts those seminars, which people agreed to have available to the public. And that's always a great resource if you're looking for a already recorded seminar. So the seminar speaker today is Dean Baker, who will be introduced in a moment by Sophie. And before they come on, let me just say that Sophie will introduce the speaker. That'll be followed by roughly a 45-minute talk by Dean Baker, our speaker. And then Sophie will resume moderating actively by taking questions first from students and then from the larger audience. So welcome, Dean. Thank you so much, Sophie, for being the moderator today, and it's all yours.
Awesome. Thank you so much. Well, hello, everybody. I'm glad to see everybody this, afternoon. Today, obviously, Dr. Baker is going to be talking to us about waste and corruption of drug patent-supported research. So Dr. Baker, I think my understanding is you had your undergrad and master's in economics before doing your PhD at the University of Michigan, focusing on economics. And I think throughout his career, he's looked at a wide range of economic topics, and is the author of 10 books, a whole host of articles that are published in major publications like the New York Times, and plenty of really large journals that we've got. I think that one of the things that Dr. Baker shared with me was that while his main work has kind of focused on some broader economic subjects, he did co-found the Center for Economic Policy and Research, which is a independent think tank that produces economic research on U.S. national affairs. So covering anything from the global economy to Social Security, healthcare, the U.S. national budget. And so I believe from there, Dean's also worked quite a lot in academia as a guest lecturer at a number of universities, and I believe the University of Utah currently, Dr. Baker. I meant to clarify that one with you.
I did for 2 years, but not anymore.
Okay, perfect. But anyways, and so I asked Dr. Baker how he kind of came to this kind of area and how he got interested in drug patents and all of this. And it was very interesting to me, the response he gave me, but it was basically that kind of earlier in his career, obviously, when free trade and kind of dismantling governmental like barriers. We're obviously trying to get rid of that with neoliberalism as that movement came along. And seeing that there was a significant amount of waste in that space of, where the drug tariffs and patents were basically getting maybe 10 to 15% of a return. When if you used a patent, you can instead increase revenue by 500 to 1,000, like almost 1,000%, or more. So I think that from there, Dr. Baker then kind of did a whole host of research and trying to understand all of this, and also in the context of some major trade deals like NAFTA or some of the other kind of free trade agreements we have, and then I sorry, Dr. Baker, to put you on the spot, but in your email, one of the lines you wrote that I thought was summed it up well was, when I raised the issue with other economists, they usually looked at me blank-faced, like patents were given to us by God. If I did get them to think at all seriously, they would usually say something like, quote, without patents, no one will develop drugs. Somehow the idea that we could have other incentive mechanisms was beyond their comprehension. I think that is a very interesting take and a great direction to go for both, I guess, your research you've done in the past and potentially future research, as you kind of get to think about a fun topic within obviously a very large umbrella. But yeah, thank you.
Well, thanks, Sophie. I appreciate the introduction. Let me just say a little more. I mean, it is odd for me to be in this space because, again, my main area is macroeconomics. I write of inflation, unemployment, budget deficits, Social Security, housing bubbles, things like that. And I did get into this, again, as Sophie had said, back in the early 90s. I realize I'm getting old, so this is ancient history for people. But, free trade was absolutely the dogma. And, I was working at that time, the Economic Policy Institute, and we were one of the major places that was less enamored with free trade. We thought there were a lot of problems with it. But the story of free trade was largely about reducing these, at least publicly, the official story was, oh, we have these tariff barriers and they're really bad, And, you try and look at it, you go, well, the tariff barriers, if you look at most of the countries we're signing trade agreements with, Canada, Mexico, in the case of NAFTA, but even other countries, they're rarely more than 10 or 15%. And you're just going, how big a difference is that? And, most of the analysis, actually their own analysis showed it wasn't very much. But, supposedly this is really bad. So I'm going, okay, what about drugs? And at that time, drugs were cheaper than they are today, but still, you had drugs that, it was easy to show that, the patents raised the price fivefold, tenfold, sometimes more. So that's 500%, 1,000%. So if, a 10% tariff is a big deal, how can a 500%, increase in prices due to a patent monopoly not be a big deal? And, again, I'd raise this with people and they'd look at me like, well, well, you have to have patents. And you go, well, do you have to have patents? I mean, we should be asking that question. So anyhow, I've spent, in my spare time, and again, not to belittle, it's just that it's not my main area of research. Trying to look at this question and can you have alternatives? And again, I'm thankfully not the only one, but there's not. I mean, the person I most point to, Joe Stiglitz, a Nobel Prize winner, who's also written in this area and written some very important work, and obviously gets more attention than I do. But it is, amazing to me at least that you don't see more discussion of the issue because it's a huge, I'll say it's a huge economic issue. You all know it's a huge public health issue, but it's also a huge economic issue. And again, it's amazing to me how economists don't realize how much money's actually there. And sometimes when I give numbers, they go, "Where'd you get that from?" I go, "Well, it's the national income product accounts. You might look at them. So in other words, that's kind of the Bible for economists. So it's kind of like you're telling a priest you better look at the Bible. That anyhow. So let me get on with the presentation and go through the, some of this and some of the specifics. So let's get started. Okay, first slide, next slide. Okay, so the four key points. First off, drugs are cheap. I sometimes give a talk and I'll start out by saying drugs are cheap, and people look at me like I'm a moron, and go, yeah, well, actually, they're very cheap to produce and deliver. It's rare. There are some exceptions, but it's rare that a drug will actually be expensive to produce. Again, it'd be a big extraordinary. Usually, it's a relatively simple manufacturing process and delivering it, you have to be refrigerated or whatever. It's not, these are not prohibitively expensive. So the reason why we have drugs that can cost hundreds or even thousands of dollars a prescription is because there's a patent monopoly. And I've had some people be a pain and go, well, sometimes it's not patents. We have other types of exclusivity. Someone went through and documented them. There's like 14 different types, I think. The most common is with data exclusivity. So, alternative to patents, but there are several other types. But the point is that these are all by law. They aren't, it's not that it's expensive to make this cup. If we made a patent on it, maybe it'd be expensive, but it's not expensive to make the cup. It's not expensive to make drugs, with very few exceptions. The second point, there's a huge amount of money at stake. Again, the 500 billion is my calculation of, what the savings would be if we snapped our fingers, got rid of all, patent monopolies, related protections, everything sold in free market, like my cup, so, everything's suddenly sold in the free market. So again, it's, 500 billion is a crude number. We'll spend around 740 billion on drugs, prescription drugs and pharmaceuticals. It's more in speculation. I mean, there's a basis for it. We know what generic drugs sell for. The savings would be around 500 billion a year, probably somewhat more. That comes to $4,000 per household. So again, this is real money by any measure, and it's I have a slide showing, making some comparisons, but one of my pet harangues is that we often have numbers thrown out that there's no context, and people hear, I'll give you one example. The AIDS program for Africa was, I think, 6 billion a year. It's like, oh, is it worth us spending 6 billion a year for, helping people in Africa? Yeah, we feel bad for them, but 6 billion, that's less than 1/10 of 1% of the federal budget. So it's the sort of thing I think people need a context for these big numbers, and putting it in context, it's a big number. The third is the monopolies encourage corruption. Again, this is, I remember my first intro econ class, probably in the context of tariffs, but I don't really remember the exact context. But the point was, when the government interferes in a market, it's like beaten into you. You can't be an economist unless you know when the government interferes with the market, it creates corruption. So if we have rent controls, which you could argue for, I actually think rent controls in many cases are a good idea. But what people tell you, okay, you have a controlled rent, well, then you're going to have payoffs to landlords, which can happen. It does happen, So you have some sort of government intervention like that, you're giving an incentive to corruption. You go, okay, but our 10% tariff that gives a percent incentive to corruption. What is a 1,000% tariff in effect, or patent monopoly that's the equivalent of 1,000% tariff? What does that do? And you don't have to look far. I mean, that's the opioid crisis was in large part, companies could sell opioids, a new generation of opioids at prices that were, 10, 20 times their cost of production because they had monopolies on them. So it's a really big deal. And the last point, again, there are alternatives. Again, I don't know how many times, it's not that I think economists are especially smart, but this is their field. So they go, if you didn't have patent monopolies, who would develop drugs? And, I go, well, we could have direct public funding, and people, you could pay people. And, I've sometimes had to yell that at people, we could pay them, we could pay them. It shouldn't be odd to people that, to economists that people might work for money. We do have some evidence of that. So again, we could argue what the best system is, and again, that's totally appropriate argument. But to act like, oh, we would never have drugs developed if we didn't have patent monopolies, that's just nuts. So anyhow, I'll go through that in a minute. Okay, next slide. Okay, in terms of, drugs being cheap, again, the exact amount we could quibble over, but we have plenty of evidence because we have generic drugs, so, we have drugs that come off patent in the United States or Europe, and we know what the generic price is, but oftentimes we could just look at them side by side because you have other countries that in some cases the drug was never patented. India is the most obvious. India is far and away the largest producer of prescription drugs in the world. And you'll often have drugs here that sell for, 10, 20, 50, even 100 times what they sell for in India. And just to be clear, India has a range, so you could get some bad drugs in India. You could probably get some bad drugs here too. But India has a range of manufacturers. Some of them, I think everyone will agree, are not up to par. But they're leading manufacturers. They're world class. They're, in terms of the quality of their drugs, they're as good as anything you'll get in the United States. Many of the drugs that our brand distributors or brand producers make, they're actually made in India. So, it's not, this isn't black market drugs. This isn't something you buy in an alley. So you can get the same drug very often in India for, just a 1%, 2% of what the patent protected price is here. So there's not really any doubt, again, whether it falls 90%, 95%, 99% in some case, it's going to differ a little bit by drug, but free market drugs, if you just had them in a free market, they would be way, way cheaper than, patent protected drugs. Just some examples, and they're really dramatic. I mean, that's why I'm picking these, The AIDS triple cocktail, again, this is, I'm realizing I'm dating myself, but, I'm sure all of you are familiar with the AIDS crisis in the 80s, and basically AIDS was a death sentence. We first developed ACT, I guess, 86 thereabout, and that was, great at ameliorating the effects, delaying the effects. But in almost all cases, people eventually got sicker and died. It only, helped you 2, 3 years. It varied by individual. But, in any case, AIDS was pretty awful back in the 80s. Then in the 90s, I think about 94, thereabout, they developed a triple cocktail of drugs, antiretrovirals, that was very effective in treating AIDS and could basically make it a chronic disease. People have lived, with the treatments for decades, and that was a real sea change. But the problem is they're very expensive. And again, they're 10 to 15,000 a year is what they're selling for here. And again, dating myself just to update you, this is mid 90s. So double those numbers. That'd be like 20 to 30,000 for a year's treatment, which is expensive in the United States. But, if you have insurance, if you're middle class, upper middle, you could probably dig up the money one way or another. It's expensive, no doubt about it. But at least affordable for, someone with insurance, a middle class, upper middle class person. If you get the government to pay for it, lower income people, yeah, okay, fine. But in developing countries, no way, and particularly in sub-Saharan Africa, where you had a per capita income at that time of about $1,000 in many of those countries. So, basically, it meant this is worthless for people in sub-Saharan Africa. And let me digress a little bit because I think people should know this story. Um, there were efforts by health groups, public health groups, to try and get the makers, Pfizer, I know made one of the drugs. I forget all. I think Merck was one. Anyhow, the big producers. It doesn't matter which ones. There were efforts to get them to make the drugs available at a lower cost to sub-Saharan Africa. And the argument was you're not going to sell it to these people anyhow. There might be a few rich people in these countries that could afford it, but it's not like you're losing a big market. So what the hell? And they said, oh, well, maybe we can give a discount, maybe we could sell at 5,000 or something like that. And they actually were saying that this is what it cost us to produce them. And, this was just a transparent lie, but this is what they were saying. And eventually, and again, I'm going to mention that someone, Jamie Love, I don't know if people know him, but, he's really kind of a hero here because he went around the world. He contacted major manufacturers in Thailand, in India, I think maybe Brazil, and it doesn't matter. And he asked them, how much would it cost you to make these drugs? How much could you make them for? And he found, I think in both Thailand and India, there were producers that said I could probably make it for $200, $300 a year. And that was a sea change because, you can get government programs, UN programs to pay $200, $300 a person. And there are, of course, millions of people infected with AIDS in sub-Saharan Africa. So that was realistic. That was something you could talk about as an aid program. You couldn't talk about that at $5,000 or $10,000 a person. So, because he was able to arrange for getting this at a lower price, he eventually was able to sell it to both the UN. So, we had a UN program. And of course, the Bush administration, the George W. Bush administration, they actually got them to start PrEPAR, which, has saved probably tens of millions of lives at this point. And it's really kind of, again, I'm mentioning Jamie Love here just because, I mean, he deserves the recognition, but also it's just an incredible example of someone who's very determined. I don't know what sort of budget he has. I know the guy who runs I'll come back to his group, Knowledge Ecology International. He's occasionally paid for it out of his credit card. It's a bare bones operation, but because he was very persistent, knew what he was doing, and he was able to have this massive breakthrough that, saved millions of lives. So anyhow, just saying what is at issue here? We make drugs expensive and it costs lives. It's a huge, huge deal. The next example, Savati, a great breakthrough drug. I think it was about 2008, 2007. I forget the exact year. So this is actually a cure for hepatitis C. So prior to that, it was debilitating disease. There were treatments that could delay it, ameliorate the effects, but people generally got sicker and sicker, and they need liver transplants if they could get them. Maybe they weren't appropriate for everyone. Anyhow, it was a pretty bad story, but they were selling it for 84,000 for a round of treatment. Generic versions were available in India for $300. And it was one of these things, there was this absurd, again, kind of painful debate here where the argument was, well, should we be paying it? Because a lot of people had hepatitis C, yeah, they were drug users, maybe they were alcohol, people who you might say had, serious social problems, whatever, so there was, and again, I'm not caricaturing at all. There was a serious debate. Should we spend $84,000 on these people? And, again, whatever we might say, whether that's a good idea or a bad idea, the point was it didn't cost 84,000. It cost $300. So if you go, should we spend $300? I don't think you'd have too much of an argument. I mean, I know there might be some types who hate these people, so I'd say I wouldn't spend a penny on them. But I think any serious person, it's a non-argument. So, again, these are extreme examples, but, I could find others. I'm sure others would identify more. It's not my area. But these are two that were, big in public debate and, cases where, again, we created a problem for ourselves by making drugs expensive. Okay, next slide. Okay, so advantage of cheap drugs. Again, maybe this is stupid and obvious, stupidly obvious, but you know, I'm sure you've all seen someone who gets cancer and the treatment costs tens of thousands, sometimes hundreds of thousands, and their insurance won't pay for it, or they don't have insurance, or even if the insurance does pay for it, they only pay half of it because they have co-pays. They do GoFundMe's. I mean, that's just people are desperate for their lives, and here they are having to do a GoFundMe, hoping they get enough money to pay for medication they need to save their life. It just to my view, crazy. Again, particularly since we've made them expensive, and I'll just contrast that being the economist here. Suppose I need some sophisticated heart surgery that's going to require five heart surgeons to spend 10 hours dealing with me, and then they have to do the follow-up. Well, that actually is expensive. Now, maybe we think heart surgeons are overpaid. I happen to think that, but regardless, these are highly skilled people. That's not disputed. Takes a lot of time for some of these surgeries. That actually is a use of real resources. So then you could debate, okay, maybe I'm 85. I probably won't live more than a year or two anyhow. You could debate that. But in this case, the drugs are cheap. We shouldn't have to debate it. So the GoFundMe's should be unnecessary. The second point, again, I think anyone involved in public health will tell you, where you have expensive drugs that maybe the insurance doesn't cover it or doesn't pay for it completely. A lot of times people don't take the prescribed dosage. They cut their pills in half, or they take it every other day. I mean, it's a big problem, and oftentimes they won't be honest about that. So a doctor prescribes a drug and it doesn't seem to be helping someone. So they scratch their head and go, well, maybe I should give you a different drug, this and that. And the big problem is they're only taking half the dose. They don't know that because the patient doesn't want to be honest with the doctor and tell them, I can't afford it, so I'm only taking half the dose. So that's a big problem. And on the third one, doctors oftentimes decide, well, drug A would be the better drug, but I don't want to give you a drug that's going to cost you, 2,000 a month, which some of these will, whatever. So I'll give you drug B that costs 100 a month, and again, that's something a reasonable thing for a doctor to decide, given that patients, obviously, there's a limit of what they can spend. And again, I'm not going to be one to defend insurers, but as a practical matter, if the insurance company is saying, looking at, the doctor wants to prescribe something, a pill, a drug that costs 50,000 a year, and there's a generic that costs a couple hundred, a few hundred, it's reasonable for them to ask the question, do you really need the one that costs 50,000? And at the very least, that will cause people to jump through hoops. And again, I don't have to tell anyone, the people in the hoop jumping situation tend to be people in bad health. So, that's exactly who you do not want to make jump through hoops. Now, maybe they have, a spouse or family member who could jump through the hoops for them, but it's really when you're dealing with a serious threat to someone's health, someone's life, you really don't want to make people jump through hoops. Next slide. Okay, just to make the point about how patent monopolies affect spending on drugs. This is a very crude graph. I'm sorry, I'm not a very good graph maker, but um, a lot of folks have the idea that drugs have always been increasing rapidly in price, that, oh, that's just what drugs do, or spending on drugs always increases rapidly. And it's actually a very interesting story that until 1980, they actually weren't increasing. This is spending as a share of GDP, just to be clear. I like to be honest with my numbers, or at least I try to be honest with my numbers. So taking it as share of GDP, I'm not playing games. So if you take spending on prescription drugs and pharmaceuticals is a broader category, there's no trend. So it's, about 0.4% of GDP in 59. That's the first year for which I have data. I could probably dig other data up, but first year that you could find easily find data. To 1980, it's still about 0.4% of GDP. There's no upward trend at all. After 1980, you can see it starts to rise very rapidly. So by 1990, it's close to 1% of GDP. By 2010, it's about 2%. If I updated this a little outdated, it'd be about 2.3, 2.4% GDP. What happened in 1980? Well, we passed the Bayh-Dole Act. So the Bayh-Dole Act made it much easier for companies, individuals to patent research that was paid for by the government, mostly through NIH, but there are other government agencies that support research. So prior to 1980 was generally difficult, I'll just say, not necessarily impossible, but difficult for companies or individuals to get a patent on government-supported research. After the Bayh-Dole Act passed, it was much, much easier. And we see that spending on drugs exploded. Now, to be fair, there was a lot of good research developing new drugs that probably would not have taken place without some mechanism like patents to support that. So we did get new drugs that were very useful in treating, I just talked about AIDS, I just talked about hepatitis C. That's great. Those were great drugs. But we weren't seeing big increases in spending on drugs prior to Bayh-Dole. Okay, next slide. Okay, so again, the context of the point I was making before about it's important to see these big numbers in context. And again, it just drives me nuts when I see we had this big fight over support for Corporation for Public Broadcasting. We spent, I think it was 550 million a year, and yet all these people going around, well, we could use that money to house the homeless, to feed hungry people. Go, okay, we could, but it's just not very much money. 550 million is less than 1/100% of the federal budget. So it just, again, you could argue, I don't care what you think of a Corporation for Public Broadcasting. But one was, it didn't really affect anything in terms of, whether people are going to pay lower taxes or, what, great things you might want to spend the money on. It really didn't change the story. Drugs change the story. Okay, we're on a path to spend about 730 billion this year on drugs and other pharmaceuticals. Again, my ballpark estimate of how much we'd save if we snapped our fingers, made it all free market, it's about 530 billion. That's big money. The food stamp budget, it's 100 billion this year. So you're talking about more than 5 times the food stamp budget. So again, the point just being this is something that matters. So again, beating up on my friends who are economists who like to look at big things. This is a big thing. There aren't many things that would be, single areas that would involve more money than if we changed the way in which we financed the innovation, research in prescription drugs. Okay, next slide. Okay, just to make that point, again, spending per household, it's more than 4,000 per household. Again, just some comparisons you might recall during the pandemic, it was a big deal. We got the $2,000 check, the pandemic checks. Well, this is 4,000, so it's twice as much. So that's a big deal. And again, this is every year, so it's not a one-time deal. So that's real money that way. Second thing, I'm involved in debates on inequality. And one of the points I often make is that inequality doesn't just happen. We design the market. We could design it differently. And, patents are a big part of that. Copyrights are too. I won't go on a long digression there, but, these are ways in which we structure the market. So I know any number of people going, oh, we can't just leave it to the market, and go, okay, well, we could argue whether we want to leave it to the market or not, but we didn't leave it to the market. We put in patent monopolies, and I'm picking on Moderna. I don't know if they're particularly bad or good in this, but just a little history on Moderna. It's a very new company. I think it got started about 1919. 2013, 2014, they're about they had never had a marketable product before they developed their vaccine, their COVID vaccine. I'm not knocking the vaccine, by the way. I'm not an anti-vaxxer. I'm just giving the history on this. They hadn't had a marketable product. Suddenly they developed the COVID vaccine, which, again, is fantastic. I mean, we needed vaccines. That was one of them. It wasn't the only one, but, we needed vaccines to stop the spread of the pandemic and, at least ensure that people who got it weren't serious, weren't hospitalized, didn't die from it. And, obviously the vast majority of people who got vaccinated did not die from it, did not get seriously ill. Anyhow, so, not knocking the product, but just pointing out, there were five Moderna billionaires by the summer of 2022. And again, in terms of the patent monopolies of protection, um, the government paid for the development of the vaccine. So this is one that, to my view is very ironic, might not be the right term, but if, the people often talk about, they give them the patent monopoly and the money they make, that's a reward for risk taking. They wouldn't have taken the risk otherwise. They didn't take the risk. We took the risk. So if had turned out to be the case, they'd gone through the clinical trials and what do you know, they don't work. Well, they were already paid for it. So they didn't have any risk there. I mean, I guess I would have been embarrassed, but they didn't actually have any risk. But nonetheless, we gave them control over the vaccine, and we got five Moderna billionaires by the summer of 2022. I don't know, their stock's since fallen, so I don't know where they stand. But in any case, the point was this is a big thing in inequality. Again, that's not the topic of this seminar per se, but it is worth noting that patent monopolies, again, along with copyrights are a really big factor in creating the sort of problem of inequality that we have in the United States and the world, but certainly here. Okay, next slide. Okay, the corruption. Again, it's, to my view, just mind-boggling that there's not more appreciation of corruption that comes from patent monopolies, again, particularly with prescription drugs, because, one, the markups are so high. But again, people are desperate. So it's not, the patents affect the price of a lot of things. iPhone, I haven't bought an iPhone lately, but I think they're probably around $1,000. If you snap your fingers, there were no monopolies on any of the software or any of the things that went into an iPhone. I don't know, $100, 150. I haven't tried to price it, but I'm sure the price would fall hugely. But it's not, if the $1,000 iPhone is too much money for me, well, okay, I won't buy it. Not a big deal. The other hand, if the drug you need to stem the growth of your cancer, you can't afford it, that's a big deal. So, again, it shouldn't be a surprise that, you get corruption with patent monopolies. I also mentioned again, this is an old story, there's an old logic, where you make drugs illegal, you get a black market. And the clear case, the obvious case here is, go back to when we had prohibition in what it was 1919, we put prohibition in effect, and we got this massive bootlegging, huge growth in organized crime. And everyone goes, well, you made it expensive, so there was a big market for that. There's not much market for bootlegging when alcohol is cheap, cheap and legal. So you take the money out of it, you make it legal, and the organized crime plummeted after the end of prohibition. So again, you could argue whether prohibition had good public health effects or not, but I don't think there's any doubt it had very bad effects in terms of promoting organized crime. Well, same story with prescription drugs, takes a little different form, but same story. Um, I mentioned the opioid crisis. And again, this isn't speculation. We know this. We had drug companies, I don't know if they ever admit guilt, but they had lawsuits where they were charged, and it's very specific. It's not that they made a mistake, it's that they knew that the new generation of opioids was highly addictive, and they lied about it. So that's what they were charged with in several lawsuits, and I think all the major opioid producers ended up with large settlements. So again, I don't think any of them ever admit guilt. I think that's always a deal. They don't ever say, "Oh yeah, we did it," but they end up paying billions of dollars, which to my view is a pretty effective way of saying they did it. So, and again, it wasn't that it was an accident; it was deliberate. Third, again, there's any number of examples. I won't try to go through all of them. I couldn't possibly, but Viax is a little dated now. But Viax was an arthritis drug, and the manufacturer Merck had evidence that it increased the risk of heart disease, heart attack and strokes with people who took it. And guess what? There's a lot of overlap between arthritis patients and people who have heart conditions. And again, they concealed this. So it wasn't just an honest mistake. And again, honest mistakes will always happen. You know, you want to minimize them, but that's life. But that wasn't the case. And again, Merck paid several billion dollars in a settlement, you know, because, you know, they were sued based on the fact that they had concealed evidence that Vioxx was harmful, that it increased the risk of heart attack and stroke. A fourth category, medical journals get ghostwritten. I believe Adrian had a story that someone had asked her, they offered her money to go to lend her name to an article, which I think speaks volumes because anyone who done any research on Adrian would know she's about the least likely person to ghostwrite an article on, you know, how great a drug was. But the practice was so common that, you know, I guess they ran out of other doctors on their list. They saw Adrian and go, oh, what the hell? Well, ask her to do it. I don't think she did it, but no, I know she didn't do it. But anyhow, you know, it's a problem. Medical journals have tried to police this, and I guess they're more or less successful. I can't really speak to how successful they are. But again, that's the sort of problem you wouldn't have if you didn't have patent monopolies when drug companies stood to make massive amounts of money from prescribing their drugs more widely. Gifts to doctors. Again, the medical profession tries to police this, but you know, can you completely do that? It's very difficult, you know, and you know, one of the way there's a thousand ways to give gifts to doctors, but one of the easy ones, give them big honorariums. Come speak at our convention in Hawaii, and we'll bring your family there, and we'll pay you 2,000, 5,000, 10,000, whatever it might be. It's very, very hard to police that. And again, I think the medical profession, I think, you know, I shouldn't say everyone, but I think many of them are trying to, many of the professional specialties, but it's very difficult to police because there's so much money there. So again, it's a huge problem. And again, it would largely go away if we didn't have patent monopolies. Next slide. Okay, so alternatives. One that's been touted in different forms, prize system. So the way a prize system, and I'm just giving outlines because it could be a thousand different ways, but the way a prize system would work, or at least the way it's usually proposed, is that, you know, basically you tell drug companies keep doing what they do, but go ahead and get a patent, and then the government will buy up the patent. You know, again, you could have it done a thousand different ways. The government could selectively buy up patents. It could decide this particular drug's a very good drug. We want to buy it up. It might say we'll buy up every drug in a category of drugs, whichever is any number of ways. It could be either mandatory or voluntary. So you could say, you know, if we want to buy the drug, there's a variety. Well, you could write the law to just say that, you know, if you get a patent, it can be bought by the government. You could write it any which way you want. Or it could be voluntary. You just put enough money on the table, tell the drug company that, you know, why don't you sell it to us? And the point here is that once it's bought up, it could be sold as a generic. So it could be cheap, you know. So this is one way that, you know, basically you could leave the current structure in place of research to a very large extent. And you just have the endpoint being instead of that you have your monopoly, your patent monopoly, and then you try to sell the drug as widely as possible, you get a lump sum, you get a big chunk of money, and then the drug can be produced as a generic and be available cheap. I should point out there are different ways, you know, there actually are ways in which something like this has been done. So I know the Louisiana prison system a few years back bought up, I think it was for hepatitis C, they bought up the right to distribute Savati, the treatment for hepatitis C, at least the first treatment, to people in the prison. And they paid a lump sum. They paid, you know, I don't know what the sum was, doesn't matter, but you know, but then, you know, they just were able to essentially have it as a generic. So you could do this in different forms. I'm just mentioning that. There's any number of ways that could be cut. So that has the advantage that you can you could leave the current system of incentives largely in place, and then you can make it available as a generic. Now, what I see as downsides to this, one is it doesn't get around the problem of corruption. I guess I'll put it that way, because who gets the prize? That's because you might have two drug companies that are producing something side by side or competing to develop a drug, I should say, side by side. One gets the prize, one doesn't. How do you resolve that? Usually when people have written this up, they say, "Oh, you can't sue," maybe, but that's it's going to be hard to eliminate political influence on that. The other is that it doesn't encourage sharing of research. So one of the big problems to my view, of the patent system is that drug companies have a strong incentive to hoard their research. So if they're doing something and it looks like a promising line of development, they don't want their competitors to get that. They want to lock that in. Once they get the patent, it's fine to obviously you have to disclose some information to get the patent, but they want to lock in as much of their own work as they can. They don't want to give it away to their competitor. You still have that problem with the prize system. You'd have that same incentive. Okay, but in any case, the point is it's an alternative to the current system that you could have another mechanism for supporting the development of new drugs that doesn't require giving a drug company a patent monopoly and charging very high prices. Okay, next slide. Okay, my preferred alternative is just direct public funding. And, again, I've raised with these people and they look at me like, "Oh, you want the government to do it?" I go, "Government already does do it. 50 to 60 billion a year. I haven't checked the latest figures because I know RFK Jr. is cutting that. I guess Doge started to cut it, but I think the NIH budget's still around 50 billion. There's other government agencies. There's BARDA, even the Defense Department. I know they developed, I'm trying to remember what it was. They developed a vaccine. I forget what it was, but it doesn't matter. You find pockets of research in like the least likely places. I think that was the Army that did this research I was referring to, but it doesn't matter. Anyhow, point is we already spend a lot of money on biomedical research. So the idea that the government couldn't do it, couldn't do a good job. Again, you ask people about NIH research, well, don't ask RFK Jr., but if you ask anyone who's a medical professional about NIH research, I think almost without exception, they'd say it's very valuable. So you have this, it's a large chunk of money. It's less than what the industry funds. I'll come to that in a second. But just about everyone agrees it's very, very valuable. So, if you say, okay, well, why can't we have them develop drugs? And usually you get some story like, oh, they could do basic research, but then they become stupid fools if you ask them to actually develop the drug. And I was going like, how does that work? I mean, what do we think, knowledge is like that, that you have people that can develop, the work on mRNA, vaccines. A lot of the path-breaking work, in fact, all the path-breaking work was publicly funded. So, what was going on that we asked them to develop a vaccine, they'd all become really stupid if they did it on government grants. And, one of the projects, I mentioned Knowledge Ecology International with Jamie Love. They're actually doing a project where they looked at four important drugs, orphan drugs, and they documented all of at least everything they could find in terms of the important research that was done to develop the drugs. And virtually all of it was done on public funding. So, the idea that there's some sharp break, and I'm trying to treat it seriously, that there's some sharp break between the sort of research that gets funded through NIH and the sort of research, that a Pfizer or Merck, some other drug company might do, there isn't a sharp break. So I literally don't even understand, what the case is that there's something different that goes on in the drug companies when they're trying to get a patent monopoly and what goes on with researchers that are working on an NIH grant in some form or other. So anyhow, I don't get that. So I don't understand. The second point, obviously we need much more. So people go, oh well, the industry spends much more. If you look at what the industry spends on research, at least in the US, and that is the bulk of their research, it's around 150 billion a year. So you'd have to triple or quadruple the public funding. So it would be a big increase in public funding, no doubt about that. But to my view, it's a question of quantity, not quality. That if we tripled it, in fact, I'd argue in a second, I will argue that you could improve the quality. So anyhow, just orders of magnitude, you would have to increase the funding, at least triple, maybe quadruple it. Again, there's some international issues I won't go into, but there are international issues with the current patent system also. So I'll just say that's not something unique to public funding. Um, how could it be done? It could be done through public agencies. Rashid Tlaib, representative from Michigan, just came out with a proposal. I think it's called Medicines for the People Act that would set up a branch of NIH that would actually carry through research in important areas. So they'd select areas where they think there's serious deficiencies in the private research or the availability of drugs to date. They'd carry through the research, carry through the whole development process, through the FDA approval process, and then they would make the drugs available cheaply, at a low cost. So they would own all the rights to them. So it could be done through a public company, through a public agency, as that's proposed, or you can contract them out. I mean, again, I've thought about this some, not to say I have the perfect system or anything, but there's no reason, at least in principle, you want to have Pfizer, Merck involved, that's fine. Just say, okay, you don't get the patent. You're going to get a grant for $10 billion, let's say, for doing research on liver cancer for the next decade or 12 years or whatever it might be. And everything you do is in the public domain. So you don't get a patent monopoly. I mean, you could take out the patent, but the patent's in the public domain. And the last point on that, if you do public funding, you could make a condition of the research that it's all open source. So it's all, as soon as you have an important finding, as soon as practical, it goes up on the web. So that means everyone could benefit from it. And the model for this was the Human Genome Project, where they had the Bermuda Principles that everyone agreed that they were going to post their results nightly. I don't know if they'll typically be practical, but the point is that as soon as you have an important finding, you post it on the web. And what that means is that researchers, all around the country, all around the world, they could benefit from the results. So if there's a breakthrough, they could build on it. If it's a dead end, you don't want duplicative research where people hit the same dead end. So if it turns out you're pursuing a particular line of research and it wasn't an effective way to treat this type of cancer, let everyone know so they don't make the same mistake. So that's an argument that it would actually be more efficient. I think that's a very plausible story. And I shouldn't have to point out that very often a lot of research is duplicative drugs by design. So, and it's not a bad thing in a patent system. So when you had the first calcium channel blocker, if having a second, third, fourth, that lowered the price. It actually, competition brought down the price. Now, not as much as if it were generic, but it did bring down the price. But as a practical matter, you probably don't want people developing the third, fourth, fifth iteration of a drug to try and take advantage of the patent rent when there are diseases that there is no effective treatment for. So arguably, that's what I'm saying. How much more would we have to spend? We have to spend in public research if it were fully open source? I think there's a very good argument to be more efficient rather than less. Okay, I think that might be the last slide. Next slide. Okay, advances. Okay, had jumped ahead. All researchers would benefit from breakthroughs, and um, the second point here is actually an important one that is worth saying a little bit about. Again, not an expert on medicine, but insofar as anything coherent from RFK Jr., yes, there are very often cases where the problem isn't, we need another drug. The problem is diet, the problem is environment. There are other factors that affect health. Well, if you're working for Pfizer, they don't want to hear about the other factors. They don't want to hear that eating broccoli might reduce your risk of it. They don't want to hear that. I mean, not that they don't care. I'll just put it that way. It's not necessarily they're hostile to it, but they're not paying someone to find out that broccoli is going to reduce your risk of a particular type of cancer. Whereas, people who care about people getting a type of cancer, we do want to hear about that. So if you had publicly funded research and it's open source, there's not a clear break. So if you discovered that some particular, food or, something, aspirin was good for treating something, well, aspirin's been whatever, it's available for how, God knows how many years. No one's going to make money selling aspirin, at least not big money. But you take away that distinction. So there's no sharp break. So to my view, I think that would be a very good step, very big step forward. Okay, next slide. Okay. Oh, the pandemic. Yes, I'll just okay, forget the pandemic. Yeah, so most of you, I'm sure, are familiar with what happened in the pandemic. We had a race to develop vaccines, and we had, of course, the US, we had Operation, what was it, Warp Speed, and it was quick, but it is exaggerated. It wasn't quite the miracle that our president likes to claim because China developed vaccines in the same time frame. AstraZeneca, it was actually an Oxford vaccine, but again, same time frame. So there are several vaccines around the world basically developed in the same time frame. I mean, it's great we developed the vaccines quickly, but we weren't unique in that. So, but anyhow, what we should have wanted, we have a worldwide pandemic. So what we should have wanted was to have a free sharing of technology across countries, both for their own lives, but also, if we had could have taken stronger steps to spread the vaccines earlier, we might have prevented new strains from developing. So again, not ancient history to anyone. We originally had the alpha strain, then there was the delta strain that actually was in many ways more severe that developed in India. You might have prevented that if we'd gotten vaccines out quickly enough. We might have prevented that strain from ever developing or at least spreading widely. And then we had other strains, Omega. We had a number of different strains that, several of them were very vaccine resistant, at least in terms of, the people still caught COVID. They weren't as deadly as the original strain, particularly if you were vaccinated. But we might have prevented alternative strains from being developed. Anyhow, what happened with that, you might recall, there was an effort at the WHO to make technology available. And basically, we, the United States and Europe, we filibustered. So we had this long debate about, oh, what would be the conditions under which we'd make it available? And the incredible thing was, and to my mind, I don't know, it's stupid, corrupt, whatever you want to say, we could have just told everyone, share the damn technology, make it all available, and we'll figure out who owes what after the fact. These were separable issues. That shouldn't be a radical proposition. It's just kind of common sense. Moderna, share your technology. We'll figure out what you should get paid. Now, maybe they're worried. Obviously, they were worried they wouldn't get paid, but they thought they should get paid. But who gives a damn? What should have been, to my mind, the obvious logical solution there is just share the technology. And after the fact, we could figure out. Again, I don't think they should have gotten the patent in the first place, but they didn't ask me. So, you got the patent, you should get money for it, but we'll figure out how much after the fact. Let's make sure people get the vaccine. And then afterwards, we know who got what, and we'll make, India pay so much, we'll make South, whatever. We could figure out how to divide that. We could do that after the fact. Those were totally separable. But because you had this crazy mindset that, oh, we had to worship patents above all, who knows how many people got sick, how many died. Okay, next one. That might be the last. Yeah. Okay. So just, conclude repeating everything. They make drugs expensive. They'd be cheap otherwise. Provide an incentive for corruption, which is huge. And, again, I'd argue it slows medical progress. So thanks for listening, and let's happy to take some questions, comments.
Awesome. Thank you so much, Dr. Baker. That was great. And yeah, thank you so much. I'm just looking at nothing in the chat yet. Do any of my classmates have questions they would like to start off with, either in the chat or if they want to unmute themselves and share it with everybody?
I saw that Adrian put in a note about drug companies' campaigns against diet and exercise. That doesn't surprise me in the least. And again, it just speaks to the corruption. I mean, my God, if it turns out that exercise reduces your risk, which obviously it does in many cases, heart disease, whatever, and I know there's all sorts of reasons why people may not exercise. I'm not getting down on people for that, but we should at least want people to know that whatever exercise can reduce your risk of this or that disease. I mean, if there's evidence for that, we should want people to know it.
Great, thank you. I guess if my classmates are still working on questions, maybe does anybody else from the general audience want to ask a question first?
So I think I'd like to just make a comment or ask a question. I think, Dean, what you're saying makes so much sense and would do so much good that, we're not lawyers, we're not economists. Maybe that accounts for some of the lack of immediate questions. But I have one, which is that if you look at the funding of research and clinical trial, basic research, clinical trials, marketing, et cetera, the cost of getting drugs to the patient is really a lot more than just, the clinical development of the drugs. And drug companies really don't do very much basic science these days. And most of that is done at universities. Universities are getting terribly squeezed today. How do you think that's going to affect this balance of, how drugs come to market, who pays for it, et cetera, and what will be the consequence of that?
Yeah, that's a really good question. I mean, the Trump administration's policy here is almost like it's designed to destroy, the development of the pharmaceutical industry. I mean, it's not that I'm crying for the pharmaceutical industry, but we do want them to develop new drugs, good drugs. And if you cut off the basic research, which they're doing at both ends, you mentioned universities, obviously a lot of NIH funding, most of it, I guess, goes to universities. So they're cutting funding to universities directly. They're cutting funding to universities indirectly by cutting NIH budgets. It is going to dry up the pipeline. Now, the plus side on this, and who knows how this works out, is that other countries are to some extent picking up the gap in the sense that they realize that there's this vacancy that the U.S. is vacating its role, its position in funding basic research, and you've had Canada, France, China. They've tried to lure top researchers, in many cases been successful. So they're looking to build up their own research in that area, which, be great for the world, probably not good for the US economy, but to have at the end of the day, we want to have effective drugs, whether they're developed in France, they're developed in China, doesn't matter. We want to have effective drugs. So I think what you might see is that, the US vacating its role there, its historic role, and other countries to a large extent picking up the gap. Whether that's one to one, who knows? But it does mean, the U.S. Pharmaceutical companies will probably be disadvantaged. I mean, one of the things, again, I think it's just ungodly stupid, and they probably know this. One of the things they often say is, "Oh, we have all this." Research done here. So much of the drug industry's research is done in the U.S., and they say that's because we have strong patent protections. You go, no, that's actually because we have public funding. So you have people who get grants from NIH, and then they go over, they set up their own biomedical, biotech company. There's all these biotech companies in the it's called the tech corridor, between Gaithersburg and Bethesda, because you had people who were at NIH, working on NIH money, and then they set up their own biotech company. So it's not our patent monopolies. It's, that we had the public funding. And if the funding's not here, if it's instead in France, Canada, China, India, we'll see that there. So as I say, I think it's unfortunate that we're surrendering our position there, but as I say, hopefully to a large extent, it'll be picked up elsewhere.
Okay, thank you. That makes a lot of sense.
Great. I am not seeing any more questions in the chat, but if there's anybody in the general audience or my classmates who'd like to chime in.
Don
Yeah, so
Light
we have.
has his hand up.
Oh, sorry.
I'm technically not very adept, so thank you for that.
Hi,
Well,
Don.
hi. Well, it's first I want to say I was so pleased to see that Dean Baker was a speaker that I made a point of setting aside time because he's really worth listening to, and I have great admiration for his work. So I just wanted to make a couple of points that can't be developed now because we don't have the time. But for decades, Western Europe, Western European countries did not allow patents on drugs, on prescription drugs. They and medicines more broadly, to use the English word. It was considered unethical and immoral to to patent medicines that are invented to help people with serious illnesses. So that's a whole another thing that should be done with an historian. You should realize how unusual the United States is. It's also unusual in a sad way that the United States is the only affluent country that doesn't have universal health insurance. And because it doesn't, it's the only country that doesn't have strong regulatory walls and reviews for how drugs are priced, the United States is far and away the most expensive place because we don't really believe in universal health care. When I say we, I mean members of Congress who are then richly funded by all kinds of healthcare corporations as well as pharmaceutical companies to not advance universal health access as every other country you can think of that has a medium to high income does. So that's another thing I think would be really good to have a talk about, a comparative study of all the damage done by not having universal health care. It's not just a matter of everyone having their medical bills picked up by healthcare, but it has all kinds of other effects on women and families and children in particular. And a third thing is that there is quite a lot of research being done without patents, but it's in places that we're not familiar with. I wrote a book called Good Pharma, which was about an Italian institute that has never patented any of its drugs because it believes that anything that it develops belongs to the public. And we never hear about it because we don't have the kind of press control that the pharmaceutical companies have. So those are just a few things I wanted to point out.
Yeah, these are very good points. The history of patents, again, I'm sure you know more about the specifics than I do, but I mean, it wasn't always the case that you could patent everything everywhere. And, and of course now we can patent light forms. That's a relatively new, innovation, that wasn't always the case. And in fact, patents themselves, I mean, it's a great story in, I think it was the 1880s. The Netherlands got rid of patents because they were believed in free trade, so
Yes.
patents are, these are government monopolies.
Right.
We're free traders, so it actually, again, that to my view, that's right. I mean, it's perfectly reasonable to argue patents are a good way to provide innovation, but let's not make any mistake. They're not free. They're a government intervention. There's you get arrested. It's I've had people say you don't get arrested. Well, if I produce something that's in violation of Merck's patent, they go to court and they get an injunction from me. And then if I continue to produce it, I get arrested for violating the injunction. So I would get arrested, so we don't have to argue about that. In terms of, how patents are structured, one of the things, it wasn't just when I was talking about NAFTA and our free trade, ostensibly free trade agreements, it wasn't just that we were eliminating tariff barriers. We were making patent barriers more stronger and longer, and we were imposing that on countries around the world. And the TRIPS Accords in the WTO, trade-related aspects of intellectual property, that we just dumped on them was designed by Pfizer. They had lobbyists that were close ties in the Clinton administration, and they just dumped it into the WTO negotiations. And they said, okay, everyone's got to take them. And it imposed US style patent controls, patent monopolies, on the whole world. And, much of the developing world did not have that. And, I mentioned before India, it's huge issue in India because they still, you could argue whether they have stronger or weaker patent laws because there's a lot of drugs that are patented in the US that can't get patented in India because part of the story of a patent is it has to be innovative. And in India, a lot of the drugs that we consider innovative that, or I'll just say have patents, are combination drugs. So, you have drug A and drug B. It's, you're using them in combinations. You get a patent for that. Well, in India in general, no. And there have been some important drugs, Gleevec, which is a very effective cancer drug, that didn't have a patent. I think it still doesn't in India. I think it never got one. But it was selling. It's a very expensive drug, and it was selling without a patent and very cheap in India. And so anyhow, how you define patents is very, very much up for grabs. And, we've always, I shouldn't say always, but at least in recent decades, very much defined patents in ways that were very generous to the pharmaceutical industry. I see someone posted, Adrian posted about Jonas Salk. It's a fantastic story. I mean, He develops the polio vaccine. He did it. It was one of the charity March of Dimes, whatever, and basically eliminated polio. I mean, we've had subsequent develops the vaccine improvements, presumably, but in any case, that was the big one. That was huge. So. My mother, grew up having to worry about polio, and she was thrilled. My brother and I were born just afterwards that the polio vaccine, we didn't have to worry. She didn't have to worry that her kids would, get this crippling and possibly fatal disease. Yeah, insulin, another great example.
So, Dean, I also wanted to say, like, I think it's probably scary to people when you talk about like how much more government money would have to be spent in this in this proposed system. But I just think it's important to point out how much money the government would save too. That even though we don't have a national health system, we're still the biggest payer between Medicare, Medicaid, the VA, the prison system, Indian Health Service, et cetera. And we would save a lot of money in the long run with this.
We would save it right away with about half this. Well, I shouldn't say
Mm.
right away because you still have the patents. I mean, you'd have to decide what you did with the current patent system. But we spend, I was putting up 730 billion a year, roughly half of that. I don't have the latest figures, but somewhere around half. It might be a little more, a little less. My guess is probably a little more. That comes directly from the government. So we're spending, let's say, 360, 370 billion a year. If you reduce that by two-thirds, which is a very plausible number, that would cover whatever you might need by way of additional research costs. So again, I don't know if you could reduce it by two-thirds in one year, the first year, presumably not, but over time you certainly could. So yeah, we would easily save many times over what you'd have to spend in additional money, and that's just directly from the government. Obviously, everyone else would, not have to worry, pay less for their insurance, and pay less directly out of pocket.
So, students, what do you think of the idea? Does it seem like a good idea? Does it seem like pie in the sky? What do you guys think? You're being very quiet.
I should also add, I know this sounds very radical, or maybe it doesn't sound radical to people, but you could do this piecemeal. That's one of the things I really like about this, that you could, fund research in a specific area for heart disease, for lung cancer, for whatever. One of the things that during the well, I guess we still have to deal with COVID. Peter Hotez is an epidemiologist. He developed a vaccine. Actually, he's developed a number of vaccines, but he developed a vaccine, Corbavax, that was widely used in India and Indonesia. Over 100 million people got it. And there it's available for 2 or 250 a shot. Maybe it costs $5 here. Moderna's selling their and Pfizer's selling their vaccine, their shots for 130. So if you could have gotten that approved, and we did work with some members of Congress to see if they can get the FDA to approve it, and they threw up an impossible barrier. They said he'd have to do a full clinical trial, which would be, ungodly expensive at this point. But anyhow, if you could find some cases like that where you could get, a drug produced with public funding or, direct funding, his wasn't public, or maybe whatever, get, upfront funding and then available as a generic, you could show here's how it works here, here's how it works here. So it's not a question of snapping your fingers and just getting rid of the patent system tomorrow, however much I might like to do that. You could do it piecemeal, and there's very low risk in that sense. That, I mean, you don't want to waste money, but if it turned out, you could get 10 billion allocated for this area of research, and turns out doesn't prove very fruitful. Again, you don't want to waste 10 billion, but you haven't shut down the drug industry.
Oh, could I add one thing before I go? Most of uh, pharmaceutical R&D goes to discovering not a better drug, but a drug that's enough different, slightly different, that it can justify another patent. So most in an article with Joel Lexton in the British Medical Journal, the BMJ, we published evidence that most of the R&D is going into slight variations that can justify 20 years more of monopoly pricing.
Yeah, that's a huge issue. When I was talking about corruption, I should have pointed that out because I'm familiar with some of your work. I don't know if that specific article, but that's a huge, huge problem. And with any of the major breakthrough drugs, you might find 40, 50, 60 patents, and probably half or more of those are total bullshit. They're just, they could be contested, but again, there's this incredible asymmetry. So if I'm a generic and I'm trying to produce a cancer drug that's competing with your cancer drug and you're selling it for $20,000 and I hope to be able to sell it for $300, I'm gonna make a profit. I'm in business to make a profit, but you stand to gain much more than you stand to lose much more than I stand to gain. So you have your bullshit patent, and how much am I going to have to spend going into court to try and argue that patent's bullshit? Yeah, I might be infringing that, but that's because it shouldn't be there. And again, that's another aspect of the corruption. And of course, you actually have bribes. They're not called that, but they're almost impossible to detect. So, you have a generic producer that's producing, 10, 15, 20 different drugs, and Pfizer goes, oh, guess what? We'd like to have you be our producer of this drug, and we'll pay you for that. As long as you drop, and they don't have a contract that says that, but as long as you drop your effort to, produce, interfere with our monopoly on this cancer drug, happens all the time. And it's almost, unless someone's really stupid, no one writes a contract that way. So, how do you ever get caught?
Well, thank you. Molly, if you would like to go ahead.
Hi, yeah, thank you for talking to us today. I was wondering, because I know that biosimilars are pretty popular, like especially with immunotherapy for things like inflammatory bowel disease. So I was kind of curious, like where that falls in terms of patents, because I know it's not necessarily exactly the same thing as like a generic.
Yeah, that tends to be a case where the data exclusivity is the more important point. So usually the data exclusivity, I won't claim to be fully up to date on the law, usually applies to 14 years after they have it approved. So what that means is that once you've developed, you have a biotech drug, biological drug that, you have exclusivity on, no one else could use your results to establish that their biosimilar is safe and effective. So they would have to do it themselves, which, raises both expenses and also ethical issues that, if you have a drug that is effective, how do you do a clinical trial? That you don't use the drug. I mean, it's I mean, I guess you could do it, but is there, if you have a drug that's effective, to not use it, to have a clinical trial where you have people that don't use that drug, that, they really wouldn't be ethical. And, if you did it, if your treatment group had as a control that they're using a drug, well, you're going to have a very hard time showing that's effective. It's basically the same drug. It's a biosimilar. So the whole point is it's basically the same drug. So
Yeah, and Dean, actually, also, I just wanted to add to Molly that like a biosimilar is exactly the same as a generic drug. It's just the generic version of a biologic, and the term biosimilar that was basically lobbied for by the biologics manufacturers to make people think that it wasn't the same.
okay, you're a step ahead of me on that. I actually thought there could be minor differences because you don't have the exact same cell line.
Yeah, but yeah, I mean, they're basically the same. That term, they didn't want to use the term bioidentical or generic, so they
That's
came up with
fascinating.
biosimilar because that sounds like they're very different, and it's extremely minor.
That's interesting. I hadn't known that history, but it's not the least bit surprising.
Okay, so we're coming up against our drop dead deadline as far as the seminar and discussion time. So thank you for coming today, Dean, and to the audience for your attention and some good discussion, albeit a little limited, but nonetheless fascinating things that were talked about here. So I'll turn it back over to Sophie, and she'll take it away from here.
Great. Yeah. Thank you so much. I think on behalf of everybody, that was a great chat and we're all very happy to hear it. If without any further questions, I guess we can disband here and I'd like to say thank you to everybody who came, especially our non-happy students that come to join. We love it when you guys are here. So thank you so much. And yeah, have a great rest of your days and weeks and enjoy the weather. Yeah.
Thanks a lot. I enjoyed it.